Hello, so this teach is going to be on the red eye and the main differential diagnoses for it. The learning objectives for this teach are going to be the main differentials for a patient presenting with red eye. So we're going to start with episcleritis and subconjunctival haemorrhage, moving on to acute angle closure glaucoma, uveitis, scleritis, keratitis, and conjunctivitis. And we'll be looking at what each condition is, how it presents, and how you'd manage it. So we'll start with episcleritis, and we'll draw an eye here, and then show you a bit what that looks like so we can talk about it. As this is a common, usually benign condition, where there's inflammation of the episcleral vessels. And around 30% of these are associated with another condition, so something like inflammatory bowel and some connective tissue disorders like rheumatoid arthritis. But the majority of them are just a benign idiopathic condition. So the patient will present, they'll be systemically well, and they'll have this sectoral inflammation, which is the redness in a particular area of the eye. Occasionally can be diffuse. It often recurs over 1 or 3 months and usually resolves spontaneously within 2 weeks. Sometimes can be associated with mild pain and discomfort as well, but nothing too serious. To differentiate the vessels of the episclera from the underlying sclera, you can try pressing them with a cotton bud, and they'll be mobile with a cotton bud. And adding drops of phenylephrine as well will cause them to blanch, whereas the scleral vessels won't be mobile and they won't blanch. So I've got a picture here just to show you what it's like. So you can see in this patient's left eye there's an area of redness, it's sectoral, and if you were to press that with a cotton bud, the vessels would be mobile and they'd blanch with phenylephrine as well. This is usually a self-limiting illness and so doesn't need specific management. You can offer a topical lubricant or non-steroidal if the pain or discomfort is bugging the patient. Think about referral if it occurs often or if it's particularly severe or persistent and won't go away. And you might want to consider any of the underlying conditions and ask about those symptoms of inflammatory bowel and so on. So that's episcleritis, just a benign condition that we'd start with. So next we'll carry on with another benign condition, so we're looking at subconjunctival haemorrhage. This is a bleed into the subconjunctival space, and it looks quite scary, so an eye filled with red blood, but usually this is a benign condition. And it's caused by the bleeding of conjunctival or episcleral vessels into the subconjunctival space. There are a number of different reasons this can occur. Often it's unknown, but it can be due to a Valsalva manoeuvre, trauma, either surgical or accidental, very common after surgery, contact lenses and putting them in and taking them out, hypertension, any bleeding disorders, and drugs such as warfarin, non-steroidals and steroids are also associated with this condition. And this will be guided by the history, but if there's no posterior margin, so if you get the patient to look sideways and you can't see behind it, you want to think about an intracranial hemorrhage or fracture of the orbit, which can cause a subconjunctival hemorrhage as well. And obviously you'll hear about this in the history of trauma or headache or so on. You want to look for associated conditions of proptosis, so the eye bulging forward, and any periorbital bruising, so what gives you a black eye. But more often than not, a subconjunctival hemorrhage is just an idiopathic condition. So how does it present? Obviously we've got this really scary looking hemorrhage in the eye, and this can spread, it can move around the eye, and it can also change colour, so like a bruise it can go to yellow and then green as the hemoglobin gets broken down. Might have some mild irritation with it, and again it can last up to 2 weeks, but usually resolves within them. So here we've got a couple of pictures of what the subconjunctival hemorrhage can look like. This is in a patient who retched and caused it. So we've got first of all quite a mild case here, and then moving on you can see this is spread a lot more and looks quite severe, but is still benign after the retching. And again you can see a medial hemorrhage in this patient, but you can also notice that there's the ecchymosis, the bruising around the eye. So this might be more worrying, thinking about trauma to the face and maybe an orbital fracture. To manage it is very similar to episcleritis. So there's often a self-limiting condition. Obviously if you're thinking about trauma you might want to consider a CT. You can treat it with a topical lubricant for the mild discomfort. You want to discourage things like aspirin or non-steroidals, which might make the bleed worse or take longer to resolve. And you want to refer any simultaneous bilateral hemorrhage a persistent hemorrhage, or a hemorrhage that keeps coming back, keeps recurring, to ophthalmology just to get it checked out. So just to say that the subconjunctival hemorrhage is normally unilateral, so a bilateral one is more concerning. So those are the two benign conditions. Let's have a look now at the more serious ones. So starting with acute angle closure glaucoma. So this is one of the ophthalmic emergencies, and it's caused by blockage to the aqueous outflow in the anterior chamber. Leads to a really acute, severe rise in intraocular pressure. So there are two main types of glaucoma. There's this one, the acute angle closure version, which is an emergency, and the more chronic open angle glaucoma, which is a more progressive, insidious condition. So what happens in acute angle closure glaucoma? Let's just draw the anterior chamber of the eye. Here we go, so that's the cornea, there are the iris, the lens and the zonular fibres attaching to the ciliary body there. And the iris a bit more 3D, and that's the lens. So the angle we're talking about is the iridocorneal angle, so between the iris and the cornea, so that's that there. And this is what gets closed in angle closure glaucoma and remains open in open angle glaucoma. So the aqueous humour is produced in the ciliary body and flows around the lens and into the chamber at the front of the eye, and then out through the iridocorneal angle and into the canal striatum. And in angle closure glaucoma, this gets blocked either by the lens being pushed forward or being pulled forward by neovascularization, and that closes the iridocorneal angle, and the aqueous humour has nowhere to go, so it builds up and it really increases the pressure in the eye. And that's what causes the problems that you get in angle closure glaucoma. So the risk factors associated with the condition are an increasing age, as your lens continues growing throughout age, a thick lens or a thin iris, being hypermetropic, as you have a smaller eye, it's easier for the angle to get shut, being female, and a family history of the condition too. The patient will present with acute onset unilateral severe pain. It's described as a boring pain into the eye. And you get blurred vision associated with this, along with halos around light when you're looking at it, and the cornea will look hazy when you look at it. And that happens because the cornea normally has pumps which remove water from the cornea on the outside, and the raised intraocular pressure causes these pumps to stop, so water builds up within the cornea, makes it hazy and reduces its refractive ability. And they'll have a red eye. Obviously this teaches about the red eye. It's described as ciliary flush around the iris, and that looks like this. And there's the hazy cornea. You also get a non-reactive mid-dilated pupil, so it won't react to light. So here's a picture of what it looks like clinically. You can see the red eye in the patient's right eye. You also see a hazy cornea, and you can see that the pupil's more dilated than the pupil on the left. And the patient needs investigating with a slit lamp exam, looking at the anterior chambers, and they're often shallow in this, and gonioscopy, which is using mirrors to assess the iridocorneal angle, and by definition they'll be shut in acute angle closure glaucoma. Moving on to the management, the aim is first of all to reduce the intraocular pressure, and to lie the patient down and apply topical drops with beta blockers like timolol, sympathomimetics, pilocarpine, which is a miotic, and prednisolone, and IV acetazolamide, all aiming to lower the intraocular pressure of the eye. And once the cornea is clear, so you can see through it, you can progress to a peripheral iridotomy, either surgery or with a laser, which is a hole into the iris to improve the drainage of the aqueous humour. We've got a picture of that. So you can see here the hole at the top of the iris from the peripheral iridotomy, which can be done with either an ND, YAG laser or surgically. The prognosis for this condition is excellent if there's prompt treatment in an uncomplicated patient. There are really good results if you manage to get this sorted out in time. If you want to know more about it, I've got another video on it which goes into it in a bit more depth if you're interested in that. So let's move on now to looking at uveitis. This is inflammation of the uveal tract, which you'll remember is the choroid, the iris and the ciliary body. So uveitis is classified differently depending on which part of the uveal tract it affects. So the uveal tract, as we said, consists of the choroid posteriorly, there, the ciliary body, and the iris anteriorly. So we've got the choroid, ciliary body, and the iris. And uveitis affecting the iris is known as anterior uveitis or iritis. And they're the most common of the uveitis. And the ciliary body has a number of different terms depending on where it affects. So if it affects the anterior portion of the ciliary body, it's anterior scleritis or intermediate uveitis. If it affects the posterior portion, it's known as pars planitis, posterior scleritis, or again intermediate uveitis, which refers to both anterior and posterior inflammation of the ciliary body. And choroid disease is just known as posterior uveitis. In this lecture we'll be looking at iritis and anterior uveitis, which are the same thing as are the most common of the uveitises. So we'll mark this up. So we've got anterior uveitis, which is inflammation of the iris, part of the uveal tract. So a number of different things can cause inflammation of the uveal tract. They're almost like a surgical sieve. So we've got inflammation, infection, neoplasia, trauma, ischemia, and then idiopathic as well. And the important thing to remember with anterior uveitis is its association with HLA-B27. So half of the causes of anterior uveitis are related to this gene. And this is conditions such as ankylosing spondylitis, rheumatoid arthritis, and inflammatory bowel disease. That's the important thing to remember in exams. So the patient will present with progressive, often unilateral red eye and pain. And there'll be reduction in their visual acuity, and the key symptom is photophobia here. And on examination you'll be able to see an irregular pupil, and I'll just draw a little picture here. So we've got the red eye, which is often a circumlimbal injection, so inflammation around the cornea, or you can think of it as being around the iris. And we've got the irregular pupil as well. So there's the pupil, and here's the circumlimbal injection around the cornea and iris, and that can spread out and become more diffuse. On further examination with a slit lamp, you'll also be able to see inflammatory cells in the aqueous humour, and that will induce a flare from the light. We'll have a photo of that in a minute. And there may be keratic precipitates, which are inflammatory precipitates that can be seen on the posterior surface of the cornea. So just some pictures now to show you what it looks like. So you can see in this patient's right eye, they're presenting with the red eye of anterior uveitis. This is a child presenting with the irregular pupil that you see, which is from the inflammation of the iris pulling it outwards. In this photo you can see the inflammatory cells in the anterior chamber. You can see the white cells and the kind of the flare that's coming off them. And this is an example of something called a hypopyon, which is when inflammatory cells build up in the anterior chamber and form a fluid level. And moving on to how to manage the condition, obviously you're going to want to think about the cause of it if they have any association with the HLA-B27 and other conditions, so think about them. You're going to refer to ophthalmology immediately, and they're going to be given corticosteroids and cyclopentalates, which is a cycloplegic mydriatic, so it paralyses the ciliary body and reduces some of the pain from that. And you want to think about some of the other causes as well, so is there any infection present? And if there is, treat them with antimicrobials depending on what's causing the infection. And think about the prognosis. It's usually very good, and around 91% of people have normal vision. And obviously you want to consider the underlying condition, and this may recur as the condition progresses and flares. So that was uveitis, and let's move on now to scleritis, which is inflammation of sclera, which is the white of the eye. 90% of these cases are anterior scleritis, though there are other kinds of scleritis as well. And the full term for anterior scleritis is diffuse non-necrotizing anterior scleritis, which is the one that medical students should be aware of. It's the one that comes up in exams. As with uveitis, half of scleritis cases are associated with systemic disease, such as rheumatoid arthritis, and it can be an indicator of severe disease if scleritis is present. So the patient will present with a diffuse red eye, so the scleral vessels, so the eye will look completely red, and when you press the vessels they'll be immobile and they won't blanch with phenylephrine. There'll be moderate to severe pain, especially on movement, as the eye muscles insert into the sclera, and when they contract they'll pull on the sclera and make it hurt. And it can wake the patient up. The globe of the eye will also be tender to touch. So here's a picture of scleritis in a patient, and you can see it might be quite difficult to differentiate between this and episcleritis. It's all going to be in the history with the pain, and also on examination, by pressing the vessels with a cotton bud. They'll be immobile, and they won't blanch when you add phenylephrine drops, as we've just said. Investigations might not be needed, but you should consider an autoimmune screen for any underlying cause, and a fluorescein angiography can be done of the anterior segment if the diagnosis is uncertain. The initial management is with a non-steroidal anti-inflammatory, such as ibuprofen or diclofenac. If that's unsuccessful, then prednisolone can be taken orally. Again, if that's unsuccessful, then a topical steroid or a subconjunctival injection of a steroid can be used. And finally, if that's still not working, you could refer to rheumatology and maybe have a trial of something like methotrexate or another immunosuppressive drug. Prognosis varies and is usually related to the underlying condition. So if there's a flare of rheumatoid arthritis, you normally have a flare of scleritis. Okay, so moving on again, let's look at keratitis, which is inflammation of the cornea. And more often than not, keratitis is caused by bacteria, so things like staph and strep are quite common. In contact lens wearers, you want to think about things like Pseudomonas, and in children you want to think of Haemophilus influenzae, or if they're neonatal, then Neisseria. Most bacteria need the corneal epithelium, so the outer layer, to be compromised in order to infect the cornea, but Neisseria and Haemophilus, so those found in children and neonates, are the exception to this. They do not need any corneal compromise. So as well as bacterial causes, there are viral causes. So varicella and herpes simplex are two of these, and herpes simplex classically causes a dendritic ulcer on the cornea, which we've got a picture of here. If you see that, then you should think about herpes simplex as a cause. So you can see this dendritic shaped ulcer in green, stained with fluorescein. Moving on to fungal, these are relatively rare, but include aspergillus and candida, which should make you think about AIDS if you see it, a candida keratitis. And finally, we've got protozoal causes of keratitis, and again these are relatively rare. We've got acanthamoeba is the main one here. This is found mostly in contact lens wearers, and is very good at surviving things like chlorine, and it isn't killed off by high temperatures. It's found in both air and water, and it's very worrying. It's a very devastating infection, and can cause blindness. So any contact lens wearer who presents with red eye should be investigated for this. So luckily the two worst infections, the protozoa and the fungal keratitis, are the rare ones, but they're the ones to watch out for. And as we said, it's the bacterial causes that are the most common. So what increases the risk of keratitis? We might turn onto a new page. Risk is raised in people who wear contact lenses. The infection can stick to the contact lens and spread to the cornea. And this is for all of the keratitis, not just the protozoal causes. Trauma and epithelial damage, as we said, can lead to bacteria moving into the cornea. Any eye disease and systemic disease such as diabetes and hypertension increases your risk as well. Moving on to presentation. The patient will present with pain in the eye, as well as a red eye, which can either be localized to the cornea and circumlimbal, or it can be diffuse. The key exam type symptom is feeling of a foreign body in the eye, a bit gritty, a bit uncomfortable. On examination, there'll be an epithelial defect when stained with fluorescein. You might also be able to see a white cell infiltrate as well. So again, some pictures of this. So here we've got a patient presenting with keratitis. You can see the epithelial defect in the cornea. This is the same patient viewed by the slit lamp, and you can see some of the corneal edema as well as the defect there. This is Pseudomonas keratitis in a patient who's already had a corneal graft. If you suspect keratitis, you should send off some corneal scrapings for culture. And also if they wear contact lenses, then send off their accessories, so their contact lenses themselves, the contact lens case and the contact lens solution to see if there's anything growing in there. So to manage the condition, you shouldn't wait for the cultures to come back. You should give antimicrobials straight away. So if it's bacterial, give antibiotics, viral, give antivirals, fungus, give antifungals, and acanthamoeba or other amoeba, give antiemebics. If you have herpes simplex, avoid steroids. So if they're already on steroids, reduce the dose and the frequency, and don't start anymore, as it can increase the risk of ulceration from the herpes simplex virus. Once the epithelium has been healed in other causes, then you can consider steroids to reduce the risk of scarring, but do not give them at all in herpes simplex. And if the patient has severe keratitis, you might want to consider admitting them. This is generally if there's more than 1.5 millimeters of diameter of the infiltrate, a hypopyon, so the pus level, any purulent exudate, or complicated disease with other eye disease. I thought I'd just mention some of the complications of keratitis to watch out for. So you can get extension either into the sclera or deeper, perforation of the globe itself, or the cornea, endophthalmitis, which is rare unless there's perforation of the globe, but is infection inside the eye itself, or panophthalmitis, which is infection of the entire eye. But if the condition is treated promptly and effectively, these complications should be quite rare. And finally, we'll look at conjunctivitis, which is inflammation of the conjunctiva, the membrane overlying the anterior portion of the sclera. And there are three main types of conjunctivitis that medical students need to be aware of. There's allergic, viral, and bacterial. So we'll talk about these three as we go and compare and contrast them. And we'll start with how it presents. So allergic conjunctivitis, you get an itchy and watery eye. It's usually bilateral, and it's usually associated with nasal symptoms like rhinorrhea. Viral conjunctivitis, again, has this diffuse red eye and watery discharge from the eye. Get a gritty sensation. Again, this is usually bilateral and is associated with an upper respiratory tract infection preceding it, and lymphadenopathy as well in the submandibular lymph nodes. And finally, bacterial. Again, the diffuse red eye with a purulent discharge as well, which can stick the eyelids together overnight. This is usually unilateral, though it can spread to become bilateral. And just to add that allergic conjunctivitis is often seasonal and associated with hay fever. Moving on, investigations often aren't needed, but you consider an allergen test for allergic, swabs and PCR for viral, looking for the organism, and swabs for bacterial, looking for staph and H. influenzae most often. And lastly, looking at the management. So for allergic conjunctivitis, you want to avoid whatever it is that's causing the symptoms. You can give topical lubricants, so artificial tears, and then things like topical mast cell stabilizers like necorandamil or antihistamines. And if it doesn't work and it's still continuing, you can consider a mild steroid as well. Next, viral is often self-limiting, so you consider things like cool compresses and artificial tears to reduce the symptoms. And the big thing here is hygiene, so don't share towels, don't rub your eyes and touch other people. It's very contagious, so try and avoid spreading it. And then for bacterial conjunctivitis, you want to give a topical antibiotic such as chloramphenicol or fusidic acid. And again, hygiene is really important, and you want to avoid it spreading to the other eye as well as to other people. So that's the end. That's all the conditions we're going to cover for this teach. So what I've got now is a quick table with all the conditions and some of their key symptoms, so we can compare them. If you wanted to pause the video here and fill it in yourself to test yourself, go ahead. So across the top we have the conditions with episcleritis, subconjunctival haemorrhage, acute angle closure glaucoma, anterior uveitis, scleritis, keratitis and conjunctivitis. And down the side we've got the redness, any pain, other visual symptoms and signs, any systemic symptoms and signs, any associated conditions, the investigations you might do, and the management of the condition. So let's start by looking at episcleritis. So the redness is often sectoral inflammation lasting for less than 2 weeks. There's no pain. Other symptoms, you might get some dryness or discomfort. Not usually any systemic symptoms. It can be associated with inflammatory bowel and connective tissue disorders such as rheumatoid arthritis. Usually you wouldn't do any investigations for it unless you considered an underlying condition. And to manage it, you might consider a topical lubricant or a non-steroidal. Subconjunctival haemorrhage You get the scary looking bleed in the eye, and that can spread or become yellow, and again lasts less than 2 weeks. No pain. Again, you might get some irritation with it. Usually no systemic symptoms. You might want to think about an intracranial hemorrhage or an orbital fracture. Usually no investigations, and manage it with a topical lubricant. Acute glaucoma. Get this unilateral ciliary flush of the red eye, and you get severe boring pain, which can cause nausea and vomiting, and it's because of its severity. Other visual symptoms, there's lots. There's hazy cornea, blurred vision, halos around light due to corneal edema, a minimally reactive mid-dilated pupil, a very, very raised interocular pressure, shallow anterior chamber, and closed iridocorneal angles on gonioscopy. Systemic symptoms, the nausea and vomiting that we mentioned. It's associated with hypermetropia, so being long-sighted. Investigate it with gonioscopy, looking at the angles, and full slit lamp exam. And manage it with topical beta blocker, pilocarpine, prednisolone, and a sympathomimetic, and IV acetazolamide to lower the pressure, and then perform a peripheral iridotomy, either surgically or laser. In anterior uveitis, you get a circumlimbal injection. You get pain as well, progressive and diffuse. You also get photophobia, an irregular pupil, and cells in your aqueous humour, as well as keratic precipitates. Often there are no systemic symptoms, and it's associated with HLA-B27, so Ankh-Spond, rheumatoid arthritis, and inflammatory bowel. You want to look systemically for any causes, and treat it with steroids and a psychoplegic, such as cyclopentate, and think about infection as well. For scleritis, you're going to get a diffuse scleral injection, moderate to severe pain, which is worse on moving the eye and is tender to touch. You also get some tears, some photophobia as well. Often there are no systemic symptoms again, but you want to consider other conditions such as rheumatoid as well. Investigate it. Maybe you want to do a fluorescein angiography and look for the causes. Manage it initially with an oral non-steroidal, then topical or oral prednisolone or injection, and then methotrexate if it doesn't get any better. Moving on to keratitis, you get a circumlimbal or diffuse redness. You do get pain, and you also get a foreign body sensation, which is the key differentiating symptom. Other signs and symptoms, you might get an epithelial defect with fluorescein, as well as a white cell infiltrate and corneal edema. Again, this is usually confined to the eye, so there's no systemic symptoms. Associated conditions, not a condition, but think about it in contact lens wearers. You want to send cultures, so corneal scrapings and the contact lens accessories, and manage it with antimicrobials depending on the cause of it. And finally, conjunctivitis, so you get the diffuse conjunctival redness, usually discomfort rather than pain. And other signs depend, so bacterial gives you purulent discharge, and then allergic and viral give you a watery discharge as well. You might look for rhinorrhea, lymphadenopathy, or any associated allergy symptoms. Associated conditions, so allergic is associated with atopy. You might want to send swabs if you're not sure what's causing it. And management depends on the cause. So bacterial, you give antibiotics, cool compresses for viral, and topical mast cell stabilizers for allergic. And hygiene as well is very important. Okay, so thank you very much for listening and watching this teach. I hope you enjoyed it. Any questions, as usual, send me an email. Any feedback as well, I'd really appreciate it. Thank you very much. I hope it was useful.